Welcome back to Echo Diabetes in a time of COVID-19, and have the pleasure of speaking with Dr. Sean Osner in primary care at the University of Colorado, who also presented a session during our series on Beyond A1C targets. Sean, welcome back, and thanks for taking the time to join us.
Absolutely. Thanks for having me back.
Pleased to welcome Tom Bateman, who's here with us to share some insights on diabetes management and remote monitoring in the time of COVID-19. Tom, thanks so much for joining us.
Happy to do so. Happy to be here.
Just in follow-up to what you shared with us back in June, we've kind of learned a little bit more about diabetes in the time of COVID and remote monitoring. And I think when people talk about remote monitoring, we often think about technology, but maybe there's just some kind of basics of an encounter in the primary care setting that you can also share with us. Maybe some effective tools that have worked for you and your clinic for remote monitoring.
Sure. Wow. June seems like such a long time ago. I can't believe it's been since June only, but we learned a lot about remote monitoring and about telehealth, for example, and just how to pivot quickly since really mid-March, April, May, June. So yeah, it's been, that was only about halfway through our journey up until now, and we've learned so much more since then. I think the most effective remote monitoring a solution or tool has been telehealth itself. So being able to see patients by video, just like so many of us have learned both professionally and personally with Zoom meetings and FaceTime and things like that, but being able to see a patient in their home environment has been enormously valuable. Being able to keep them home and safe and not come into the office and have unnecessary exposures of our staff and our other patients, and also not exposing them, has been great. But really seeing some of the things that, again, that you can't see in the office. So being able to see when if they forget their meter, for example, which happens more often than maybe we'd like. That excuse is gone, right? It's right there at home. You can go get it. We can look at it together. I had a patient describing to me actually this morning what he has for his usual breakfast, but I reminded him that our last visit, which was actually virtual, I saw him eating his breakfast and I knew exactly what he was eating. So that insights like those have been terrific.
So the first thing that I think I really tried to do is just change my interview skills. So I think that when I'm meeting with patients on site versus through a telehealth visit, I think I'm just trying to use a completely different approach, or maybe just an enhanced approach, I guess you could say. And one of the things I think is really important is changing the way I would ask questions about the social history. So we still are asking questions about depression, anxiety, and using screening tools like the PHQ-2 and the GAD-2, and different questionnaires about sleep and alcohol use and smoking. And depending on those responses, we take the conversation further. We still do that, but I'm really trying to focus on where are you living? What type of housing are you in? Are there stairs in the house? What other family members are in the house? Who do you come in contact with? How do you get food into the house? What sorts of transportation do you rely on? And I'm really trying to learn a lot more about the patients in that regard, because that really shapes my treatment recommendations. And I've learned so much, about my patients. And actually, I think that there are things that we've learned at the health center about our patients that we would have maybe not otherwise known. So that's been kind of an interesting change. So that's my first approach, is changing my questions and interview with the patient, focusing on that social support, social history.
What are some tips you might have for other healthcare professionals based on your experience with diabetes remote monitoring, and kind of what can be done, maybe just as a first step for people who might be intimidated by remote monitoring and telemedicine in general, and might not feel like they're experts in diabetes? How can they get started?
Great question. So the first thing I would encourage of providers is to work with their patients, develop rapport, and see what a patient is willing or able to do. So many times patients already understand if they have pre-existing diabetes, they're familiar with the concept of checking blood sugar. So maybe that's a place where you can start. And I would say that having your patients check the blood sugar at varying times throughout the day has been helpful for me to identify episodes of hypoglycemia or hyperglycemia. And if you are identifying someone who is having these spikes, either highs or lows, are there medications that you could potentially change? So things that will lead to hypoglycemia are sulfonylureas and insulin. And if your patient has not yet been treated with something like an SGLT2 inhibitor or a GLP-1, is there an opportunity to switch those high-risk sulfonylureas, insulin, over to something that's safer and kind of easier to manage remotely, like SGLT2 inhibitor or GLP-1? And if you finally do make that change, making sure you have all the practical things in place, addressing insurance coverage for those medications and addressing the actual teaching of any kind of devices. So if somebody's using a GLP-1 for the first time, make sure that they're getting the proper teaching either through video on site at the pharmacy or some sort of other teaching device. I think those would be the first things for diabetes management specifically.
And what would be some tips you have for other healthcare providers in terms of supporting patients in remote monitoring?
I think to be open to and to promote for patients really how much good can come of staying at home, having those comforts like I was talking about, having a visit from the living room. And even though, again, you can't get everything remotely that you can get in person, taking advantage of the things that you can get that are about as good or as good or as meaningful, but B, really focusing on the things that you can do remotely that you can't do in the office, because there is opportunity there.
And what's been your kind of experience feedback from patients in remote monitoring? Are they enjoying this? They prefer in person, a little bit of both?
It's a little bit of both, but I would say that the feedback on remote visits has been great. They really appreciate the opportunity, well, on many levels, right? They appreciate the opportunity to be safer at home, even though we're doing great things in our offices and in our institutions to ensure people's safety. There's still nothing safer than not going out at all, especially in a time like this. So they've really appreciated the opportunity to do that.
You mentioned before time beyond range, and obviously continuous glucose monitors can give a lot of information. There's other ways to get information besides CGMs, but with respect to CGMs, what have you seen in terms of prescribing habits or approval or uptake in terms of patients requesting it or payers paying for it?
Sure. I've seen more interest in it, I think, because people they've been expanding their thing. We've all been expanding our thinking beyond our usual patterns, right? We've been forced to think a little bit more outside the box than usual because COVID has really messed up the box. So I hear it brought up more often by patients. I hear it brought up more often by providers. Insurance coverage I haven't been paying probably as close attention. I tend not to notice when things sail through easily, right? We tend to notice more when things are denied and we have a lot of legwork to do to try and get it covered and do additional paperwork. I feel like I've been seeing less of that additional paperwork. I've also seen an interesting willingness of some patients to consider self-pay, especially with some of the some of the systems require more hardware than others. But the ability to use, for example, rather than use a freestanding dedicated CGM reader, for example, if you can use, for the systems that are able to use a smartphone without a dedicated reader, there's not that added expense. And for some people, this, I would say, the ADA recommends using CGM as close to daily as possible in order to have it really be meaningful. But there are cases where maybe intermittent would be okay. perhaps more so for type 2 diabetes than type 1 diabetes. Just 1 or 2 sensor sessions might sometimes be okay. And I've had a couple patients who've been willing to pay the full out-of-pocket cost for a couple of sensor sessions, and they've learned an unbelievable amount.
And the final tool that I'm really using is relying on evidence-based medicine for our diabetes treatment. So I'm looking at different guidelines. I'm trying to pay attention to the algorithms. I'm trying to pay attention to new trials that are coming out and to new drug approvals that are coming out. And with that information, I'm trying to address things like therapeutic inertia. So when I'm seeing patients on sulfonylureas and I'm seeing patients on insulin, I'm asking myself, does this patient maybe have a comorbidity that could maybe open the door to changing to an SGLT2 inhibitor, to a GLP-1? And if we're able to do that, we've already reduced their hypoglycemia risk, and maybe we can rely less on that glucose testing altogether because we've switched them to some other medication that's maybe safer, just as effective, if not more effective, and doesn't really rely on those strict glucose logs to titrate and make adjustments.
Thank you, Tom, so much for joining and sharing with us, and want to remind everyone about the lectures that are available on demand that touch on a bunch of topics we just talked about. We have a lecture on COVID-19, leveraging telehealth and remote monitoring to support patients with diabetes. There's another one on continuous glucose monitors and beyond A1C targets in the time of COVID. There's an additional one on platforms to support remote diabetes monitoring in your practice. And also with regards to diabetes education, nuts and bolts of remote insulin adjustments and diabetes education. Encourage you to visit our website and share these resources with others in your group and practice. And thanks so much for joining us and being a champion for people living with diabetes.